It's so lovely to be here with you all this evening. We have these meetings every quarter, these dinners every quarter. If this is your first one, please come back. I hope you had a really great time, but for me at least, it's a really special time, especially working from home. I don't know what's happening. I'm sorry, I don't know what to do.
No, there's your mic.
Okay, thank you. Thank you. No, I'm just kidding. But for me, especially working from home and visiting our partners abroad, but it's really great to be here with you all tonight and see so many familiar and just loving faces. So tonight I'm going to be focusing on where we work, what we do, and some of the values that underlie our work and keep me working here for over 11 years. So I'll be focusing most of my examples on our partners in Kenya and Guatemala. And we do have our partners also in Haiti here with us tonight, but they'll be sharing a bit later. Next slide, please. Great, so looking to where we work. And this is something that I have heard time and time again from our international volunteer team members, that you really don't know it until you get there. And I know many of you have seen these communities firsthand. Over the past 43 years, over 40 years, we have worked in many parts of the world, across continents, across cultures, across languages. And I was thinking about kind of what ties these together, and there's some I wanted to highlight for you tonight. First, most of them are rural. This is our project area in Guatemala. But more than that, we consider them to be forgotten communities. These are communities that have been all but abandoned by their government. We think about what our government provides to us. They provide an education system, they provide infrastructure like roads and electricity, they provide a police force. These are very absent in the communities that we work in. For example, in last year, of our first-time mothers in Guatemala, less than 2% of them had graduated high school. And the bulk of them didn't even make it to middle school. The government services are lacking, and I feel like lacking isn't a strong enough word. Usually in this case, nonprofits and other good do-gooders around the world will come and help fill this gap. However, the areas where we work are often, they're off the beaten path. They're too far away. They work in areas where the local language is still spoken, the local dialect, I guess, is still spoken. And so these provide some pretty big barriers for organizations because it can be more costly, it can take more time. These communities have a history of being mistreated by outsiders. And so letting new people in can be really challenging. And so they remain forgotten. Next slide. Our goals in these communities are simple. The first, to reduce maternal mortality, which is between pregnancy until around 40 days postpartum, reduce child deaths, so children from 0 to 5, and reduce child malnutrition. Now, malnutrition is really important because a malnourished child is much more likely to die from a disease like pneumonia or diarrheal disease or malaria than a well-nourished child. And when mothers are dying in labor and children aren't living to see their 5th birthdays, it's incredibly hard for communities to thrive. They need these lives in order to create a stable foundation of society on which to grow. In Guatemala, when we started working there, over 90% of the deliveries occurred in the home. And the maternal mortality rate was noted as one of the highest in the Western Hemisphere. These are areas of incredible need, and they also provide an opportunity to make an incredible difference. So, next slide, please. Thank you. So going into what we do, and I was told not to get into the weeds too much, because I can talk and talk a lot about our partners. But I think it really is important to highlight kind of the how of what we do. And I think that's because the how is tied up so much with the why. I mentioned earlier that I've been with this organization for over 11 years, and a lot of that is because of the values in how we do our work. And I'm sure that these values are also some of the reason why many of you are here tonight. So I'm going to start actually with, can you go back one? Thank you. That was my bad. Impact-oriented, two foundational aspects. The first being our impact-oriented programming and community mobilization. And then I'm going to talk just briefly about some specific examples and activities that we do in communities around the world. Building local capacity, health counseling in the home, and health facility strengthening. So first, impact-oriented programming. This is the idea that to make the biggest impact, we must focus on the most common, frequent, serious, preventable or treatable diseases and causes of death. Now, this might seem really intuitive, and in some ways it is, but I must tell you, it's really not common. So often, donors will show up, or do-gooders, or governments will show up with a program already in mind without thinking to gather the baseline data they need to effectively make an impact in that area. They have a package program, they assume that malaria is a high need, for example, in a community, and they show up and implement. This methodology and these values require us to first ask, how can we make the biggest impact before doing? And that is because we have limited resources. We have, as demonstrated by this cup at the top of the page. So if we had all the resources in the world, of course, there are so many needs in these areas. However, with limited resources, we need to be very strategic in how we focus those resources in order to make the greatest impact. This groundwork takes a lot of time and resources, but it's also very important. And we've learned throughout the years that you can't go off of assumptions, and it's really emphasized why this step is so important. So for example, when we started working in Kenya, the Ministry of, we told them we're coming for a project on maternal mortality, child mortality, and malnutrition. And the Ministry of Health was like, this is great, welcome, would love to work with you. However, you're probably not gonna see that maternal mortality is such a big issue. According to their records, they're about on par with Kenya overall, which is still quite high, but they were at least amongst the average of the country. However, when we did our baseline data collection, we found that the maternal mortality rate was actually much higher. It was around 3 times the national average. A rate at that time similar to countries like Sierra Leone, Afghanistan, places where it had been noted as a critical need, an emergency for maternal health. Okay. The other foundational piece is community mobilization. This is pretty much that we are engaging community in the programming, with the programming. They are seen as true decision makers and partners with the programming. This is realized in a lot of different forms, some listed here on the screen, such as community assemblies to get initial buy-in and feedback from the community, formation of village health committees, which provide an important part of learning from the community and finding where the gaps are, and also addressing new needs, and then also sharing data with community. This to me is so incredibly important because it emphasizes that how we see our community partners. Oftentimes when data is collected, it's not shared back with those who it's collected on. And I think by intentionally sharing that data with those who it's collected on, recognizes them as a true partner in this process and elevates them as just somebody who we believe can do it and really matters in this whole program. Lastly, if anyone has spent time with Henry Perry or read his census-based impact-oriented methodology manual, we have this quote down here, everyone counts and everyone is counted. And when we start working in communities, the first thing that we do is we map out our project area and we go home to introduce the program to the family, collect some household data, and this is so that, and I have to say that this is a really important step. Not everybody does this. In fact, most of the times we've heard from families that this is the first time a nonprofit has shown up at their door, that a government agent to introduce a program has shown up at their door. This is showing them that their opinion matters, their data matters, they are part of this program with us from day one. Thanks. Now I'd like to go a little bit into the how of how we work. And focusing on a common thread of building local capacity. So with all of our programs, we really focus on building the abilities of those who live and work in these communities. Oftentimes these people are women in the communities who we elevate as health leaders, such as the woman here in the photo. In care groups, for example, we build the abilities of local mothers to train their neighbors on regular health lessons. Just to dive very briefly into care groups, one of the main ideas with care groups is that simple actions can lead to big results. A simple change can lead to a healthier child. We can see this, for example, with diarrhea and how it's managed in the home. In cultures around the world, it's pretty common that if your child has diarrhea, you stop food, you stop water. This is actually really bad for the kid because they can become dehydrated really quickly, and is part of the reason why diarrhea is still one of the top 5 killers of children around the world. Through care groups, mothers teach mothers other simple behavior changes that they can do with the resources they have in their own homes in order for their children to live a healthy life. We also work with traditional birth attendants. These are the long-standing members of the communities. Before there were clinics and doctors, there were traditional birth attendants. They have been delivering babies in these communities for hundreds, if not thousands of years. And in Guatemala, they are one of the people, I'd say maybe the person who has the greatest say in how that delivery and postpartum process goes. Unfortunately, it's really common around the world for these people to be discarded or rejected. Instead of that, our programs invite them in. We recognize that they also want the best for these mothers and children in their communities. So how can we work together to reach that? In our Guatemala program, this is put into practice through monthly training sessions for these amazing women, and where they learn about danger signs and also come to know and trust our Casa Materna staff, where they have a very active role in the delivery process. The last aspect of programming we want to focus on is health counseling in the home. So another way we build local capacity is by training and supporting community health workers. These workers, such as the woman seen seated here, is often from the community, speaks the local language, knows the local culture, and will remain in the community if for some reason Impeccable Health Alliance disappears one day. These community health These community health workers make regular visits to the homes of pregnant women and children in the first 1,000 days, which is that critical moment or critical window between pregnancy and the first 2 years of life. This gives them the opportunity to provide one-on-one counseling, and particularly to the influencers in the family. So we see in this photo, we have the mother-in-law, the husband, and the mother with her child, along with the community health worker. The person who has the least amount of power in that household is often the mother with the young child. After that, it's the spouse, and as all good sons do, they listen to their moms. So bringing these other key influencers into the health education is incredibly important for helping to kind of take down some of those barriers to putting them in practice in the home. Here's a quote I wanted to share from one of our community health workers in Kenya. "I've created a level of trust in the village. Even people call me at night as in telling me, 'Our village doctor, how do we handle this issue?' I explain to them and then tell them that tomorrow I will visit and assess the situation." This for me really captures the meat of it, of why it's so important to build capacity from the ground up. And that is because in areas where distance is a barrier, transport is expensive, you have somebody local that you know, that you trust, that you can call when your child gets sick, or you get sick and you don't know if you need to go to the hospital. These community health workers are a lifeline of support for families, and that is why they are so critical to our programs. We must not forget that our community health workers are also part of the communities that they serve. We have seen multiple stories of how health workers have actually taken the messages they've learned and used it to improve their own lives and the lives of their families. In Haiti, we had a mother who knew what to do when her husband started having really violent diarrhea. because of her work with care groups. There was an outbreak of cholera in the area, and she knew the signs and symptoms of cholera, but what she also knew is that seeking care early is really important to make sure that person doesn't pass away. In Kenya, we had a community health volunteer who, after learning about the signs and symptoms of breast cancer and how to do a self-breast exam, identified a lump in her own breast, and she was able to receive timely treatment and is in remission today. The last aspect of our work that I want to talk about today is health facility strengthening. So if we're focused all on community education and we're asking people to seek health services, we need to make sure that the health services are good and accessible and complete, and that there's staff there and that they have supplies. So I do think that our Guatemala partners have really exemplified this aspect of our programming. They created, in an area where there wasn't any health services, they created their own Casas Maternas Rurales, which are maternity centers located in the highlands of Guatemala. And there they provide 24/7 respectful maternal care in the local language. I want to emphasize respectful maternal care in that they have just a whole system to monitor it, and it's so important for, especially in these communities, to make sure that women keep coming to these health facilities to deliver. This is a population where they have experienced terrible abuse in the Ministry of Health facilities and the private clinics. The trust has been broken with the medical system, and so these Casa Maternas have provided a safe space to deliver for these women. And we'll be hearing from one of those women at the end of my presentation. So that's a picture of a Casa Materna. In Kenya, we have also worked to strengthen our health facilities. These health facilities are run by the Ministry of Health. However, there are still some gaps. For example, when we added nurses so that we could provide 24/7 care, electricity was an issue. I was there one night, actually, in Kenya, just hanging out with the night nurse, trying to see what their day or their night was like. And the electricity went out, and it's so sudden. And when it goes out, it is the darkest dark ever. And I can't imagine delivering children in that kind of situation, or you have a laboring woman. Usually there's more than one woman there, right? So you have a woman in labor, a woman who you're helping deliver, and all of a sudden you're without electricity. So one of the big things we've done to help support these partner clinics and encourage women to use them is putting solar panels, which allow for 24/7 power backup. So looking at all of this kind of together, we have our impact-oriented programming that's based on the actual needs of the community, where we can make results. We have community mobilization, making sure that community members are not only part of the project, but they're part of the solution as well. We work to build local capacity of hundreds, if not thousands, of local health champions within these communities, many of whom are mothers themselves. And we also work to strengthen existing health facilities, or in cases where there are none, build our own. With this, we can get some pretty spectacular results. So Anne will be sharing our results from Kenya. However, I wanted to share some from Guatemala. We have these years grouped in clusters, so 2011 to 2013, 2013 to 2015, and 2017 to 24. That's for the people the data folks in here. We can look at it and talk about it more later. But the main thing is that over this course of time in our Guatemala communities, there's been a 51% reduction in maternal mortality rate, which is incredibly impressive, and I'm so proud of all the work that they do. Before I switch to the video, I just wanted to thank you guys so much. We couldn't do it. Oh, I always get emotional. Okay, we couldn't do it without you, and your support really means a lot. Let's just turn on the video. Anyway, thank you so much.